We have a number of drugs that most drugs in practice will have this dose response effect where you start a drug, it doesn't matter what the drug is. Here's some older classic drugs. All three of these we don't use as much as we used to. One is theophylline, which is used as a bronchodilator in asthma, which we rarely use anymore, but occasionally do. Digoxin affects heart rate and heart rhythm, and we sometimes use that in certain heart rhythm problems. And lidocaine, which we more often use as a local anesthetic when you're suturing someone or you're getting a dental procedure, but it also has some cardiovascular effects as well. Like any drug, you give a certain amount of a drug and a tissue concentration that occupies a certain percent of receptors, you get a certain percent of responses. Let's sort of give a different example though here. Let's talk about a drug that will lower blood pressure. So let's say we're going to give a very commonly used drug to lower blood pressure called lisinopril. Lisinopril is an angiotensin converting enzyme inhibitor. It inhibits an enzyme that affects the renin-angiotensin system. So a little bit of the dose of the drug in most patients results in some decrease in blood pressure, and more dose results in further decrease in blood pressure until you occupy a maximal dose and affect that enzyme to its maximal effect where you don't see any more effect. So you will see a measured decrease in blood pressure that is associated for most patients with a dosage range. Classically, the dosage range that we see a drop in blood pressure with lisinopril for most patients is somewhere between 2.5 milligrams of lisinopril a day and 40 milligrams of lisinopril a day. So if we give less than 2.5 milligrams of lisinopril, we don't see any measurable drop in blood pressure for a patient who needs hypertension control. Once we get more than 40 milligrams on the sort of right end of this blue highlighted area, we get what we just basically would see is the most bang we're going to get out of lisinopril at lowering someone's blood pressure. And lo and behold, we'll have to go to a different receptor to further lower their blood pressure if we need to. As you open up a drug monograph or a drug reference, you'll typically see what this dosage range to produce whatever this effect we want is for most drugs. Those are usually based on population data. On average, most patients with lisinopril will start with a dose of 2.5 or 5 milligrams and work our way up to 40. There occasionally might be a patient who responds to a lower than 2.5 milligram dose, and there might occasionally be a patient who requires more or responds to more than 40 milligrams of lisinopril, but that's unusual, and the differences might be related to genetic variation or some other factor that we'll talk through throughout the year. But almost every drug that we use in practice has this S-shaped curve, whereby you see a certain dosage range associated with a certain physiologic property, and that's really related to this concept of how many receptors are occupied by this drug at any moment in time that is correlated with the dose we give the patient. Occasionally, we look at blood or plasma levels of a drug when there's a correlation between a blood level and a physiologic response, and the drug really requires us to be careful about how we dose that drug. So the great majority of drugs we use in practice, we don't get blood levels or plasma levels of the drug, but occasionally we do. And so we'll come back and talk about this concept sometimes in pharmacokinetics and then throughout the year for those drugs where this is an issue. Another concept we'll talk about here is the difference between potency and efficacy. And let's use the example of a couple of different diuretics. Let's first look at this diuretic called bumetanide or Bumex. It's a fairly commonly used diuretic that is pretty effective. It's called a loop diuretic because it works in the loop of Henle in the nephron. And we see here from the dose response curve that anywhere between 2 and 10 milligrams of Bumex or bumetanide would be expected to produce a pretty robust urine volume in an hour. And this is a drug we're going to use, for example, a patient with heart failure and a fluid accumulation where we want to get a lot of fluid off of them. So typically between 2 and 10 milligrams of Bumex, I expect to see, in the range of 150 to 300 or so, 400 milliliters per hour. A second loop diuretic very similar to Bumex or bumetanide, is furosemide or Lasix, very commonly used. This is probably the most commonly used diuretic in the hospital and even outpatient. It again, like Bumex, very similar effectiveness. The issue, though, or the thing that's different about Lasix furosemide compared to Bumex, is that I need more milligrams of the drug to achieve the same efficacy. So, because both drugs produce a similar amount of urine volume in most patients within their normal dosing range, these are considered virtually interchangeable or equally effective drugs. The difference here is the potency. And all the potency refers to is I need to give more milligrams of furosemide to achieve the same efficacy that we see with Bumex. It's not a big deal. That's a very common thing, but these would be considered Bumex and furosemide, bumetanide and furosemide would be considered equally effective for the most part, but difference in potency. A third diuretic that works at a different mechanism is a thiazide diuretic, like hydrochlorothiazide. Even at the maximal dose of hydrochlorothiazide, I don't get all that much urine volume in an hour. If I'm lucky to get maybe 100, 150, 200 milliliters in an hour. And so even within the classic dosage range of hydrochlorothiazide, I am never going to achieve the same efficacy that I see with loop diuretics like bumetanide and furosemide. So I can't even compare potency because, first of all, the assumption is I have to have equal efficacy to compare potency. So the most important issue really is efficacy, and then potency just refers to what dose I have to give to achieve the effect I want. So you'll see here that the median or the middle line, the higher line is the efficacy, the median efficacy of bumetanide and furosemide, and yet the median efficacy of hydrochlorothiazide is less. So they're not equally effective. I mean, at least the hydrochlorothiazide is not equally effective to bumetanide or furosemide. I can't even compare potency with hydrochlorothiazide because I've got nothing to compare it to, except maybe another thiazide diuretic. But I would be able to compare the efficacy of Bumex and furosemide because they're equally effective. Then I can start to look at the issue of potency. Okay? Another concept that's important to consider is what we consider the therapeutic index. And this concept is sometimes a little hard for people to grasp, but it's really not all that complicated. This is the degree to which the dose I need to be effective compares to the dose I need to be toxic or even lethal. And it would be calculated by the formula at the top. The therapeutic index is what is the median dose that's lethal divided by the median effective dose. So the lethal dose, LD50, is the dose at which the median dose in laboratory animals, the 50th percentile, what dose would the patient or would that lab animal die, compared to the effectiveness dose, what dose would the 50th percentile, the median person or median animal, need to achieve the therapeutic benefit we're achieving. And the wider that is, the wider the therapeutic index is, the more difference there is between the effective dose and the lethal dose, the safer the drug is. Contrary to that, the less that therapeutic index is, the closer it gets to 1, the more dangerous that drug is. And so while in practice we don't often have a calculated number for a therapeutic index, clinicians have, that's by animal models for the most part. We don't have that data usually. But what we do understand is that when a drug that we prescribe for a patient, not much more of that drug can pose a risk for serious harm or death, we get worried about, is this patient going to be reliable in taking this drug? Would I get a negative outcome from this drug that's serious by using it for the patient, particularly if the patient is not reliable to go to clinic appointments, to get lab testing done, to know and report to us if they were to see a problem with the drug therapy. So therapeutic index becomes an important issue for us in clinical practice. Some drugs have a narrow or a small therapeutic index, and those drugs, they're drugs that we are hesitant to use in patients who aren't very adherent to their therapy. An older drug, digoxin, cardiac drug, or theophylline, pulmonary drug, have narrow therapeutic index drugs. Most of the drugs that dissolve blood, not dissolve, but that affect blood clotting, that affect the clotting cascade that can be helpful for use in patients who have clots, also pose a high risk for bleeding. And those drugs often have a narrow therapeutic index and, as such, are more dangerous drugs to use. And so we're very careful about who we would prescribe one of these narrow therapeutic index drugs for. Another way to look at this is a wide therapeutic index drug would be the dose level on the left. The dose response curve for the therapeutic benefit is, well lower than the dose range that's needed for a toxic effect for the drug. Drugs, example here might be a lot of antibiotics like beta-lactams like penicillins and cephalosporin antibiotics, with the exception of anaphylaxis, would be, in the dosage ranges aren't really associated with a lot of other really serious toxic effects. And so patients could take 3, 4, 5 times the normal dose without a real serious problem. Drugs, however, with a narrow therapeutic index is often an overlap in the dose range that would achieve a beneficial effect and the dosages range that would produce a serious toxic effect. These, again, the anticoagulants, particularly the drug Coumadin or warfarin, is classically considered a narrow therapeutic index drug. The very dose that is used for one patient to help prevent them from having blood clots in another patient, that very same dose could be lethal and cause a fatal bleeding episode. There are a few other pharmacodynamic things that can happen, and I'll refer to these fairly quickly. One is that over time, the number of receptors can modulate or change. That doesn't happen for most drugs, but it can happen in some situations that something changes in the drug receptor, either the number of receptors or the shape of the receptor. This can be related to drugs. This can be related to diseases. Some drugs where we see this modulation in number of receptors, the classic one I can think of are the opioids like morphine, heroin, where over time the receptors and the number of receptors change as you get chronic exposure to the drug, that you need more and more drug to achieve the same effect. That's not common, but it is possible with other drugs. But with opioids, it is very common. Another issue is that some diseases actually, over time, you see a change in the receptors where the drugs or the hormones work. And a classic example of this is type 2 diabetes, where the insulin receptor changes as the disease of diabetes type 2 progresses, and patients require more insulin to achieve the same beneficial effect. There can also be either desensitization or supersensitization of receptors over time, either the number of receptors, again, as we alluded to, or the response of each of those receptors. And again, the issues for decreased responsiveness in insulin receptors is an example, and supersensitivity responses can be seen with a few situations. One of the ones that we'll talk about is rebound hypertension after folks stop certain drugs to lower blood pressure that work through the autonomic nervous system, like clonidine or sometimes beta blockers. More on that later in the year. The rest of our presentation will focus on more specific receptors. And some of these, I'll sort of highlight the ones that I think that are important for you as a clinician to begin to become familiar with in greater detail. Some of this, usually we focus on, okay, just focus at this juncture on general terms, but there's a few of these, as I allude to, that I think it's important for you to recognize these receptors or receptor types. And particularly, we're going to talk about the ones that affect the autonomic nervous system in a couple of minutes, but there are some that are listed in these charts that I want to sort of highlight. One of them is the top group receptors, the gamma aminobutyric acid or GABA receptors. GABA is a naturally occurring neurotransmitter that slows down nerve conduction. So, if I were to give a drug that is an agonist at GABA receptors, I would expect that that would affect slowing nerve conduction. And that might be helpful in situations where I want to slow nerve conduction related to seizures or related to pain or related to sedation or anxiety or something like that. And we'll see that the barbiturates and the benzodiazepines are GABAergic, GABA drugs which are agonists. We also have a benzodiazepine receptor antagonist, flumazenil, which is a antagonist for the benzodiazepine receptor, working through GABA receptors again. And we're not going to focus too much on that now, but there are a lot of different drugs that you'll see GABA, particularly in neurology and in psychiatry as well. We will talk about the acetylcholine receptors in depth in a bit, and they are subgrouped into the nicotinic and the muscarinic receptors on this slide and the next, and we'll talk about a lot of examples for those in a couple of minutes, so hold on to that. There are glutamate receptors, which have a host of different neurologic effects. The glutamate receptors, when we give agonists, modulators, or antagonists, can be used for a host of things. On the right, the drug memantine is a drug used for helping diminish or slow the progression of Alzheimer's type dementia. Acamprosate on the right-hand column is a drug that is used, among other things, related to certain patients who have habituation or abuse issues. And ketamine is a drug that's used as an IV anesthetic that also has some subtleties in the way that patients who experience it get dissociative reactions. And we'll talk much more about these specific drugs later in the year, but just recognize here's another receptor that has sort of modulation at those receptors, has some significant effects through the system. The other acetylcholine receptors we alluded to, we'll talk about in a few minutes. These muscarinic receptors, we'll talk about where those fit in practice and how we modulate them. There are other specific receptors. The adenosine receptors we're going to talk more about in cardiovascular medicine. I don't want to talk about those yet. But the adenoreceptors, these are adrenergic receptors. These are receptors in the sympathetic nervous system. We are going to talk about this group of receptors in depth. There's lots of examples here, but don't worry about them at this juncture. But in a few minutes, we will talk about those receptors and if we give an agonist or an antagonist at each of those receptors. There are also receptors which augment all kinds of other different systems. Here in the bottom of the slide are the angiotensin receptors that affect renin and angiotensin. We give angiotensin receptor blockers as a first-line modality in a lot of cardiovascular situations, particularly hypertension and heart failure. We also have a number of other sort of specific types of receptors. Calcium sensing receptors that are sometimes used in renal disease, cannabinoids. We'll talk about dronabinoid used in marijuana, used for in pretty widely accepted in medicine for patients who have a loss in appetite, and that's been used for years, but lots of other evolving uses for cannabinoids, particularly in seizures that are not responsive to other conditions. We also have a number of other receptors that are listed here. Dopamine receptors. Dopamine, we have both peripheral and central dopamine receptors, some in the central nervous system, some in the peripheral nervous system. We'll talk much more about those in neurology and in psychiatry for the most part. Subsets of GABA receptors, subsets of histamine receptors, histamine 1 receptors, like Dramamine or diphenhydramine, Benadryl, used for allergic rhinitis, for example, and histamine 2 blockers like famotidine, cimetidine, used for stomach ulcers. We have opioid receptors. We alluded to those briefly in subsets of receptors there, and a number of other types of receptors. So this gives you a picture of the kinds of, a few of the very widespread numbers of different types of receptors there are.